Okay, this is for my LPN students, and so our skill for today is postpartum assessment. Postpartum assessment, and so this is going to be our patient. She is immediate postpartum, so we've gotten her back to her room, and so we're going to assess her and make sure everything is okay since she's had her baby. Um, I want to make sure that I allow her to get up and go use the restroom. That's important to do that. Let her use the restroom. If she can't get up, if it's contraindicated for her to do so, then I'm going to offer her bedpan usage and help her with that. Once she gets back in the bed, I want to make sure that she is lying in a flat supine position, all the way flat down supine, not tilted left or right, or not the head of the bed not up. So flat supine position. I want to make sure that I do my safety practices. So we're going to identify the client by two means. Verify our doctor's orders, wash our hands, explain the procedure, gather our supplies, don appropriate PPE, which is our gloves here, um, make any necessary assessments, report any abnormal findings when we're done to the charge nurse or the healthcare provider, whichever that be. Raise the bed appropriate working level. When we're finished, lower the bed, lowest position, side rails up as per hospital policy, and the call bell in reach. Also, since we are going to be exposing certain private areas of mom, I want to make sure that I provide for privacy. So I want to make sure that door is closed to the hallway. Hopefully we're in a private room, but if not, for some reason, we're going to make sure that the curtain is pulled, that we make it as private for mom as we can. Also going to let mom know that parts of this are going to be very uncomfortable, and I know that they're uncomfortable, but it's something that has to be done. Um, okay, so what I want you guys to do is write down an acronym that will help you remember postpartum assessment, what sections to do, and all that. And so just write down on a piece of paper, bubble he, bubble he. And I'll spell that Bubble, second word He, bubble he. So the first letter in the acronym is B, and so that is the breast. And so I'm going to explain to mom that I'm going to expose her breasts now. And so we actually have two types of moms that we will be examining her breasts. And we have the lactating mother, which means she is going to breastfeed. And we have the non-lactating mother, which means she has chosen not to breastfeed. With the lactating mother, it is okay if we stimulate her breast and cause milk production because that's what she wants. If it is a non-lactating mother, we do not want to stimulate her breast and cause milk production because she is not going to breastfeed. So what we're going to start out with the lactating mom. And so what I'm going to do is just look for signs and symptoms of that her breasts are symmetrical. They look the same. Her nipples look the same. They're pointing, her nipples are pointing in the same direction. Do I see any cracks or fissures in her areola or nipples? Do I see inversion of the nipples? Do I see anything that might lead me to believe that she would not be able to breastfeed? I'm going to talk to her about breast engorgement. I'm going to let her know that this is something that might occur on the third or fourth postpartum day. And so signs and symptoms of that would be that her breasts are feeling firm and tight and stiff and painful. It is very painful from what ladies tell me. So any, vein distension, does she see that? Any of those types of symptoms, that is breast engorgement. So I'm going to also tell her then how to prevent that. So I want her to wear a good form-fitting support bra. Now notice I want her to wear a support bra because it's a little bit different from our non-lactating mother. So good form-fitting support bra that prevents that pulling, sagging, tugging on her breasts all the time. I want her to breastfeed the baby as often as the baby wants to feed. So as much as the baby wants to breastfeed, mom needs to breastfeed that baby. That will keep her breast emptying all the time. If the baby is asleep, let's say, and mom feels that feeling of fullness and she feels she needs to breastfeed, but the baby is asleep, she can use a breast pump and pump her breast milk out. She can save it in the refrigerator for about 3 days. Some textbooks will say a little more than that. I don't I don't like that. I go with 3 days. Or she can freeze it for up to about 6 months. She can freeze her breast milk. So she wants to do that. I want her to take some good, if she does feel like she's developing breast engorgement, or she does in fact get breast engorgement despite all these things we're trying to prevent, she can take hot showers 3-4 times a day, and that will help give her some relief of the pain. It'll help cause her breast tissue to be a little bit more soft and supple than it would be, and that will help the baby continue to be able to latch on. If the baby isn't able to latch on, he won't be able to breastfeed. It's going to be painful for mom. She's going to get frustrated. The baby's going to be frustrated, and they'll quit. So, encourage her to take those 3 or 4 showers a day hot and keep the breast soft and supple. All right, so then I'm going to palpate, and so while I'm palpating for those signs and symptoms, but really, the nurse is not going to see these signs and symptoms in this patient. I'm really teaching her a lot of this, what to look for when she goes home. So I'm going to palpate all of her breast tissue everywhere, and I'm also feeling for lumps. This mother may have breast cancer and doesn't know it. So we're going to assess for lumps, and that's why I was looking for dimpling and visual lumps, and the nipples change direction, inversion of the nipple, anything like that. Those are all signs of a tumor there, a lump there. So I'm going to palpate for that. Now, if in fact I feel a lump, let's say in her right breast, and it's at the 3 o'clock position here, I'm just going to remember that. I'm not going to record and report that yet, because it could simply be a full milk duct. And so what we're going to do is, as soon as mom feels like it and she's ready and the baby's ready to breastfeed, we're going to bring her the baby and let her breastfeed. After she gets done breastfeeding, I'm going to come back in there and I'm going to check that area again, that 3 o'clock area in the right breast. If that lump is gone, full milk duct, no problem there. If it's shrunk dramatically in size, full milk duct, no problem there. But if the lump is still there, it's still that same size that I felt, it's still firm, then I'm going to report that to the healthcare provider and let the healthcare provider follow up with that. Okay, so that's pretty much good with her. The non-lactating mother, I'm going to assess for the same exact things, but the difference is I'm not going to palpate her. I don't want to stimulate milk production because she's not going to breastfeed, so we don't want any stimulation to occur to her breast at all. So basically, just going to simply do a visual inspection. Breasts are symmetrical, nipples are symmetrical, nipples aren't changing direction. I don't see any visual dimples, wrinkled areas, anything abnormal. Mom, do you feel like your breasts are getting firm or tight or painful or, stiff or anything like that? I'm looking for vein distension. Do I see any of that? So I'm looking for all those areas. In both of these mothers, this is a great time to ask, Mom, do you do your self-breast exams? If they do, kudos to Mom that they're doing those. If they don't, I'm going to ask Mom, would she like to learn how to do self-breast exams, but not at this time. This would not be an appropriate time to go into it, but ask her. Bring it up, ask her if she would, and say, I will come back at a more appropriate time if you would like to learn, and bring you some materials and teach you how to do that. All right, so now with the treatment for mom, non-lactating mom, is to prevent her from getting breast engorgement, is I want her to wear a tight binding bra. So remember, the lactating mom is a good firm form-fitting support bra. This, I want a good tight binding bra. I don't want her breasts moving at all. If she is going to shower, I want her to shower with her back to the shower head, not with her breast to the shower head, because that will cause milk production and certainly lead to breast engorgement, or could. So I want her to shower with her back to the shower head and stay that way, getting in and out of the shower. Okay, so we're going to go to the next letter, which is the U, and that is the uterus. And so what I'm going to check for on the uterus is I should feel a spear-like ball, grapefruit size, softball size sphere down in mom's abdomen here, and that would be the uterus, and that would mean the uterus is contracted up, and that's what we want. If the uterus is not contracted and it is laying flaccid, open. We call it a boggy uterus or uterine atony. Uterine atony or a boggy uterus. It's flaccid. What that happens is mom will continue to hemorrhage. She will just pour the blood, hemorrhage, hemorrhage, hemorrhage. Okay, because it is when the uterus contracts up into that ball, it's squeezing on those blood vessels and contracting them down to stop that bleeding, slow that down. So usually then at 1 hour postpartum, which Our Lady is here, the uterus should be at the umbilicus or maybe 1 finger width above. And so that's where I'm going to palpate in, is right in that area. And so what I want to do though is I want to make sure that I prevent inversion. If you just press down in there, it's possible to push the uterus, invert it, and push it out. So we don't want that to happen. So I'm going to locate her symphysis pubis bone here. I'm going to turn my hand vertical. I'm going to come right up above the symphysis pubis. I'm going to let mom know that I know this is going to be uncomfortable, very uncomfortable for her, but it has to be done. And you're just going to press down in there. So I'm just pressing down in there. And then I'm going to come up here where the uterus should be, and I'm going to palpate down in there and just press down in there and see if I can find that sphere down in there, that softball grapefruit sized sphere. And so if I feel that, that is normal, that is what I want, that means it's contracted, that's good. That means her bleeding should be being controlled. I'm going to continue to monitor her bleeding, but it should be being controlled. That's a good thing. That's what we want to see. Okay, so if in fact I press down in here and I palpate for that sphere-like object and I cannot find it, okay, then that means her uterus is boggy. It is flaccid. Okay, now there is 3 things, all right, 3 main things that I want you to know. There are other things I'm sure that can cause it, but 3 main things that pretty much are going to be the cause of it. And so the first one is bladder. So that's our next B. So what we're going to do is we're going to do a quick assessment of the bladder if her uterus is in fact boggy, because I've got to get that tightened up. So a full distended bladder will cause the uterus to be flaccid and boggy. After mom delivers the baby, all that extra fluid that she had in her body, the body recognizes that the baby's gone, so it doesn't need all that extra fluid anymore. So the kidneys start diuresing. They start putting it out. What the problem is, though, or can be, is where mom had a vaginal birth, her receptors are stretched in the bladder and they're not functioning properly. So the signal is not getting sent from the bladder to the brain that she needs to pee. She doesn't realize it. She doesn't feel she needs to go. And so the kidneys are diuresing. They're filling up the bladder. The bladder is distending, all right? But she's not going. She's not emptying. Well, when a bladder distends and starts to push up on the uterus relaxes. It just goes flaccid. And so you've got to get that urine out of the bladder to get her uterus to stay contracted. So what I'm going to do then is I'm going to simply ask mom first, Mom, have you voided since you've had the baby? I'm not going to tell her uterus is flaccid or anything, but that's what's going on. So, Mom, have you voided? She goes, no. She should be voiding. All right, she should be voiding, 150 milliliters every time she voids, so large amounts of fluid. So she should be voiding. Do you feel like you need to go? No, she doesn't feel like she needs to go. Okay, so then I'm going to, get down and I'm going to look across. Do I see a lump here in the bladder area where it gives the appearance to me that the bladder is distended? Now remember, we let her go to the bathroom before we started this, so her bladder should be empty. So she either went or she told us she didn't need to go, all right? And so we started this, and so her bladder should be empty. And so I see this lump there. So that causes me suspicion. So then I'm going to percuss, and I hear a dull thud where an empty bladder, because I let her go to the bathroom or she denied needing to go, should have a timpani sound, and a hollow sound, an empty sound there. To that, all right? And then I'm going to palpate, and so I palpate down in here, and I maybe feel a grapefruit softball-sized thing down in there, but that's too low to be the uterus, so I'm thinking, okay, that's got to be the bladder. And so that makes sense. That's why the uterus is boggy. So you got to get that urine out of there. So take her to the restroom if it's not contraindicated for her to go to the restroom, and run some water. Tell her she's got to go. Tell her she has to go. Her bladder is full. So run some water. Let her play with her fingers in the water. I have poured lukewarm water over the perineal area, and that's worked really well. If all else fails, though, you will have to cath her and get that out of there. That has got to go. So with doctor's orders, cath her and get that out of there. Once, if that's the problem and we get the bladder emptied, here's what you do to get the uterus to contract up. So again, I'm going to come here right above the symphysis pubis, my hand vertical, and I'm going to press down in there. And I'm going to put my hand here where the uterus should be, and I'm going to massage that area. I know that's uncomfortable for mom, but this has to be done. So I'm going to massage that area and keep massaging, just keep massaging, and what will happen is you will feel that uterus just firm up like a ball right under your hand. It's a very cool, really neat thing. I've experienced it myself, so I thought it was just an amazing thing. And so you literally feel it just come up like that right under your hand there, and it will firm up. And so it should stay that way from there on out as long as she keeps voiding. So you're going to have to check that. But as long as she keeps voiding, she should not have any problems there. You want to assess the uterus every 15 minutes for the first hour, and then you're going to assess every hour after that, and then every shift after that if no complications. So full bladder is the first thing that can cause boggy uterus. The second thing, if we do assess the bladder, and that's not the problem, so she does not have a distended bladder, she has been voiding. All right, so the next thing is placental fragments. So what I want to do is, if I have detected that I cannot find the uterus there, I'm going to expose the perineal area. I'm going to pull her peri pad down. So she would have panties on and peri pad. I'm going to pull those down and pull the peri pad down. And then I'm going to do the massage again. And what I'm looking for is placental fragments. So that's the second most common thing. If she's got placental fragments stuck up in the uterus will not contract up. It will remain flaccid and boggy. So when I start to massage to firm it up, I'm going to watch and notice, does anything shoot out? Do I see placental fragments come out on the peri pad? And so then I'll know, I've got to notify the healthcare provider. Third thing then is clots, large clots, or a uterine tear. So if I see bright red bleeding coming out, I'm going to notify the healthcare provider because it's probably a uterine tear. If I see large clots coming out, again, notify the healthcare provider because the uterus won't stay boggy, until you get all of those out of there. So that's our three major culprits that causes our uterus to be boggy. And so again, I'll just demonstrate to firm it up though. Once you've found what the problem is and you need to get it to contract, locate the symphysis pubis, hand vertical, push down pressure there and push and start massaging, and it will firm up like that. Okay, so then we will go back to the bladder now because I didn't get to finish. I was mostly concerned with the distension. But the other questions that I want to ask about the bladder is, Mom, were you voiding okay? Did you have any hesitancy, urgency, stinging, burning when you peed, anything like that? So I'm looking for signs and symptoms of a UTI. If she, in fact, had any of those signs and symptoms before she came in, we want to check. We want to get a UA. We want to make sure that we get her, if she has an infection, that we get it treated while she's there. Okay, so the next thing, then the next B, so we've got breast, uterus, bladder, bowel. Bowel, we did our bowel sounds before we started the uterine pressing and stuff like that, so we've got our bowel sounds. And then I'm just going to ask her, Mom, when was your last bowel movement? Have you had any trouble with constipation or diarrhea? If she does, what does she use to help with constipation, help with diarrhea? I need to let her know that she needs to have a bowel movement by the second day, not to hold it, because the longer she holds it, the worse it will get. I'm going to help her choose good foods in her diet to help her have a bowel movement while she's there. So we want high fiber, fruit, and I want lots of fluids. Okay, so then the next thing that we're going to go to is the L, which is the lochia. And I'm going to come around because I'm going to turn the mannequin over because this is what I would need Mrs. Smith to do. So you always want to make sure that that you turn the patient over. I know it's uncomfortable. I know they don't want to do that, but this is a necessary. It is possible for the lochia, her bleeding, to be missing the pad and going down and pooling underneath her, and she could be hemorrhaging and we wouldn't know it. And that has happened before. It's rare, but it has happened. So I want to make sure that I lift my patient up. So I'm going to ask Mrs. Smith if she would reach across and grab the bar. And I'm going to help her here. And I'm just going to get her lifted up and over here. All right. And so once I got her turned up, that way I can look here at the bed underneath her and see if there's any pooling of blood there. So now I'm going to just talk about the lochia. And so I'm going to don my appropriate PPE. I want to get my pen light or a flashlight so that when I do look, all right, that I can see what I need to see. Okay, so once we got her up, I'm looking underneath here. Okay, I don't see anything there. And then I'm going to look in her perineal area. And before I do that, let me explain. Two things about the lochia that we're looking for, and then and so first thing is about the first to third day, so 1 to 3 days, you're going to see lochia rubra. You need to know these terms, lochia rubra. And so that is much like a normal menstrual flow color. And so that's what I expect to see. That's what I want to see, that normal menstrual flow color, 1 to 3 days. Then from about the 3rd to the 10th day, it should go into lochia rubra, or excuse me, lochia serosa. And lochia serosa is a brownish colored discharge. And again, they're going to have that from about 3 to 10 days. And then from about 10 to 14 days, which it can be up to 6 weeks, we're going to have lochia alba. And lochia alba is a white to clearish discharge. And again, it can go up to 6 weeks checkup. So that's what I'm looking for. The second thing then is when I remove her peri-pad, I want to assess how much is this lady bleeding. So I'm going to remove that peri-pad from front to back. All right, so I'm going to take it from the front and move it to the back like that, and then get it and look at it. So you guys can Google, about this and just get some pictures about this, but I'll describe it as best I can here. So if we have a heavy amount of bleeding, it's a peri-pad that is almost fully saturated. Not quite 100%, but almost fully saturated, and we're going to call that heavy bleeding. And then if you have, if the peri-pad is about that long, and I have this much of a streak of blood and about 2 inches wide or so, so it's not quite end to end and side to side, we're going to call that a moderate amount of bleeding. And then it's a light amount of bleeding if we have about a 3-inch line, maybe a 1 inch wide, we'd call that a light amount of bleeding. And then if it's just a stain, it's a scant amount. We'll call it a scant amount. And so what we're trying to determine, though, is it hemorrhage, and do I need to notify the healthcare provider? So if I am removing a fully saturated pad every hour, a fully saturated pad, 100% saturated every hour, that is hemorrhage, I'm going to notify my healthcare provider. But first, I'm going to check the uterus, right? I'm going to make sure that my uterus is staying contracted, and that is not the cause. So check for hemorrhaging there. I want mom to remove her pad every time she goes to the bathroom, but certainly within every 2 hours, absolutely, to prevent bacterial growth. But I want mom to do it every time she goes to the bathroom. So if she goes to the restroom every 30 minutes or every hour, I want her to change that peri-pad. When she does change it, or if she does have a bowel movement, I want to make sure that she uses her peri bottle with Hibiclens soap. That's the red soap. It's usually in the room there. So they can put several squirts of the Hibiclens soap in water and use their peri bottle to clean themselves off as necessary. Make sure that they're in a situation where the water will go up and hit their perineal area and run straight off, and not go up into the vagina or anything like that, because I don't want to wash any kind of E. coli bacteria or anything like that up into her vagina, which would set up a bad infection and she could become septic. Okay, so that's the lochia. I'm going to look at the episiotomy next, and the episiotomy is I want to make sure that it is well approximated, that there is no bleeding, that the sutures are intact. I'm going to assess her pain for that. I want to look for any kind of edema. I'm going to assess for infection. Now, again, I probably won't see this, but I'm teaching her this. So signs and symptoms of infection, foul smelling odor to it, it's swelling, erythema, redness spreading outward from it, a discharge coming from it. So if she sees any of those, I want her to come back to the doctor and, like I said, assess her pain. I'm going to do treatments here in a minute, so I'm going to go on. I'm going to look at the labia majora, and the labia majora, what can happen is when the lady has the vaginal birth, is she can stretch, the labia majora will stretch there, and it can rupture small blood vessels, and those blood vessels can start to bleed and pool the blood underneath the skin, and she ends up with a large hematoma on the labia majora. So I'm going to look for that. Let's see, I'm going to look at the hemorrhoids. That's the H. So in our bubble H-E-E, that's the H. So we're going to look at hemorrhoid. And because a lot of ladies get hemorrhoid when they do all that pushing and stuff, so I'm going to assess her for hemorrhoid, bleeding, assess her pain there, scale of 1 to 10, and all that. So our treatments for these things, if she has, in fact, I see that she's developing a hematoma on the labia majora, I'm going to put cold compresses on that. That will cause those blood vessels to constrict down and will control that bleeding. Then the body will take care of the rest of it. Her episiotomy pain, sitz bath. Lots of sitz bath, warm water, as warm as she can stand it. And then she has lidocaine spray, or Americaine spray is what I'm used to. It's just lidocaine. And so a couple of squirts of that on the episiotomy numbs it, and so she will feel much better there. On hemorrhoids, sitz baths again are very soothing, very comforting. On hemorrhoids, and then Tuck's medicated pads. Now with Tuck's, I think the main ingredient there is witch hazel, and so you just put a couple of Tuck's medicated pads right up on the hemorrhoid, and then put her Parapad right over top of those and just keep it pushed up on the hemorrhoid. It's cooling, soothing, shrinks swelling, stops itching, and does all that kind of stuff. So I'm going to put, once I've assessed all that area, I'm going to put her new Parapad back on, and again we're going to go put it down on the front and bring it to the back. So put the front side down on the front and then bring it around to the back. So at no time are we tending to pull E. coli or anything up over her episiotomy or anything like that. Okay, so I'm going to go ahead and let her turn back. Okay. And so then we're going to move on to the next E, which will be her extremities, And so what I want to do is I want to assess her extremities for circulation. Moms can get DVTs after they have had a baby because they are bleeding, and so the body's kind of chunking out that fibrinogen and platelets and all that. So it is possible for mom to get a clot, and the most common place is the calves of the legs, although we're going to check all the extremities, okay? But we want to look at pulses, capillary refill, skin color, skin temperature. Look for all those things. I'm going to look for edema in the feet and ankles, and I'm also going to assess for signs and symptoms of a DVT in the calf, which would be a reddened area in the calf of the leg. I'm going to palpate ever so gently. Does it feel warm to the touch? Do I feel a hard knot in the center of that red area, or a cord-like feeling to it? And is there edema developed from that reddened area in the calf below? All right, so is there edema there? So all of those would be pretty good signs and symptoms of a DVT, and so I would want to notify the physician, tell my patient not to move, put her on complete bed rest, and notify the healthcare provider, and then probably going to get orders for Doppler and see if there is in fact a clot there. So we want to do all that on the extremities, and then our next E, or last E, is emotional needs. Emotional needs. And so remember, mom has been through a rough time delivering this baby, and her hormones are all out of whack, and so she may have some postpartum depression, and so she may be crying a little bit, and just doesn't feel good, and even though everything went fine and the baby's fine and all is good, but she's still kind of crying and all that. So that's just postpartum blues. So what you want to do is you just want to treat her special. Go brag on how well she did. I don't care if she didn't do well. Go brag on how well you thought she did, and get her little snacks and some soda and crackers and just whatever. Try to make her feel special. Now, if there is a thing called postpartum psychosis, and then that is where the mom, there's something else going on psychologically, and so if this mom says anything about she doesn't have a baby, she didn't have a baby, she doesn't want that baby, don't bring a baby in here. If you bring the baby in here, I'll harm it. If she says any of those types of things, don't bring the baby to her. There's something else going on. Notify the healthcare provider, and the healthcare provider may want to get a psychiatric consult. However, I want to reiterate something. If she just doesn't want the baby for right now, this mom is tired. You don't know what she was doing prior to coming in to have this baby. And so she may be just totally exhausted. So if she doesn't want that baby right now, don't force that baby on her. If she is tired, let her sleep. And then once she wakes up from some rest, she'll say, bring me my baby. I'm ready to have my baby. But let her have that rest. Some moms need that. Some moms are like, bring me my baby right away. And that's all good. It's all good. But a mom that doesn't want her baby right away doesn't mean she's had postpartum psychosis. It just means she needs to rest. So postpartum psychosis is when they really start saying derogatory stuff about the baby. They didn't have a baby. They don't have a baby. They don't want the baby. If you bring a baby in here, I'll harm it. Those types of things, then you need to investigate further, and don't bring the baby to them. All right, and so that is it, I think. And the rest of it is in my handout. So just go along with this video with my handout, and you will get all the pieces and put them together. And as soon as you can, videotape yourself doing a postpartum assessment and send that to me, and I will watch it and grade you. All right, and so that's it. Goodbye.